From the American Academy of Pediatrics.
Oral health care for children can be complicated, and for children with developmental disabilities, the stakes get even higher.
A recent clinical report offers ways we can help pediatric dentists treat this vulnerable population.
We're working with our pediatric colleagues to figure out how to assess pain. Is it pathologic or physiologic? Is it related to teething or is it related to something else?
But first, it's the beginning of the month, and that means we get another rousing research roundup.
The numbers are big, the trend is impressive, but the outcome data right now needs a prospective study. So the beat goes on.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with the August edition of First Up.
Zelda's last well baby visit was her 6-month-old appointment, and it's one of my favorites because of all the anticipatory guidance. And we got a lot on starting solids and feeding. And I'm a foodie, so introducing my baby to food is a lot of fun.
6-month-old checkups are the best, and it's also fun to hear how different pediatricians give anticipatory guidance. I know one thing our listeners can anticipate. This will be a blast of a podcast because it is time for First Up.
And who better to ask about anticipatory guidance than the editor-in-chief of Pediatrics himself, Dr. Lewis First.
So, Lewis, what is your favorite piece of anticipatory guidance to give families at their 6-month-old well visits?
Well, this is a time when summer is here and we're putting infants into pools, although we're supervising that. And I always like to say, what causes dry skin after swimming in a pool?
We don't know.
Chlorine?
No, a towel. Got to put the towel around the 6-month-old because that takes care of it. Yeah, it results in dry skin, but the kids like it a lot. Another one I like to say is, if you want some anticipatory guidance, what should a toddler wear to go swimming in the summer?
We're not going to guess right.
No, I'll give it to you. Ready?
Yeah.
Pull-ups.
Oh.
Pull-ups. Pull-ups.
Oh, yeah, pull-leg.
Yeah, I'm anticipating the fall already since we've already exhausted the summer season. But there's so many great anticipatory guidance tips, but there are also some wonderful tips and things we can share from the August issue of Pediatrics.
And because we started talking about babies, let's get into a study discussing some of our smallest babies in the NICU, our very low birth weight babies, or VLBWs. These are very small infants that tend to have a patent ductus arteriosus, and we as neonatologists debated for decades about what might be the right treatment for a PDA, but now there's this option of doing a catheter closure. Is this something my subspecialty should be embracing?
Well, let's talk about the patent ductus arteriosus, or the PDA, which is that little connection between the aorta and the pulmonary artery that in the babies you take care of, Joanna, if that thing doesn't close, can result in respiratory distress, heart failure, a host of complications. And so we know, as you say, there have been a number of ways to take care of this. Physiologically, just let tincture of thyme do it in the first couple days. If that fails, there's pharmacologic treatment, meaning ibuprofen, indomethacin, acetaminophen. And if that fails, then we go to either surgical ligation, and over the past couple of years, our friends who are mildly invasive cardiologists in the cath lab have devised a coiled wire mesh device that they can feed up in the cath lab that gets between the aorta and the pulmonary artery and closes off the duct, what you call transcatheter closure. So the question is, now that you have something that doesn't need surgery and doesn't respond to drugs, is transcatheter closure the way to go? And Dr. Brianna Leahy from the University of Vermont, little shout out there to my alma mater, and colleagues decided to turn to a database, I would say tiny, but it's anything but, in the Vermont-Oxford Network, which is a collaborative network, not-for-profit, of neonatal intensive care units that take care of exclusively preterm and very low birth weight infants. I know almost every neonatal intensive care unit in the country is involved in either an NIH network or the Vermont-Oxford Network. And in this time, Dr. Leahy and colleagues took a look at 216,000 babies between 2018 to 2022 who were between 401 and 1,500 grams, very low birth weight, were between 22 and 29 weeks in terms of their birth gestation, and said how many of these babies have a problem with their ductus. Turned out that 41,000 plus had problem with their ductus, and of those, 96% got better with pharmacologic treatment. That left about 4%. That's still 6,000 babies. So we have a big sample size to try out the transcatheter closure versus surgical closure. And what's interesting is each year they study, 2018 to 2022, the number of babies that needed a little more invasive or mildly invasive, the transcatheter or the surgery, was about the same. But that's where the study gets very interesting. In 2018, 29.8% of these babies got transcatheter closure. In 2022, it was almost 72% are getting transcatheter closure. I'm sure at CHOP, where you are, Joanna, that's probably the flavor of the day. And the question then means, well, that must mean transcatheter closure is the better way to go. And unfortunately, or interestingly enough, in this study, the differences between the outcomes of transcatheter closure and surgical treatment are almost equivalent. There is a mildly, when you have big numbers, you're going to get statistical significance, but minimally clinical significance in survival. 1.03 for an adjusted relative risk, meaning a better survival, versus 1.0 for surgery. So transcatheter is slightly better. No difference in length of stay, complications, what these babies go home on, gastrostomy tubes, tracheostomy, all the same. Yet everybody's voting with their feet and going ahead to with their catheters to transcatheter closure. So the authors of this study say, well, we have some limitations. This is retrospective data. Who made the decision as to who was going to get the surgery? Maybe it was an institutional decision. We don't know about costs. Prior to 2018, when they were just trying this device, transcatheter closure was much more expensive. The question is, what is it like in 2022? That's not in this study. So yet many people are doing it. So we said, we'll get a second opinion. So we turned to another large health network, Pediatrics with an X, where we went to their senior vice president for research, education, quality, and safety, Dr. Reese Clark, and Dr. Viral Talia, one of the pediatrics neonatologists. This is a network of 375 NICUs. And so they see a lot of babies with PDA. And Dr. Talia is at the Baylor University Medical Center in Dallas. And we said, what do you think of this study? And the headline of their commentary is the importance of timing when evaluating treatment of PDA. And they point out that this is really apples and oranges. We don't know anything about the timing of when the surgery was done versus the transcatheter closure. They said, this is a little device that's going between the aorta and the pulmonary artery essentially forever. What happens up the road to these kids who get this device? And then there's the neurodevelopmental aspects. This is a very short-term study. So both the authors of the study, Dr. Leahy and colleagues, and Dr. Reese and Dr. Talia all come together and to get to the heart of the matter, so to speak, they say what we really need is to take this large series of patients, many people trending to transcatheter closure, and now let's get them in a prospectively well done, methodically organized, collected. Let's do a prospective study and get some long-term follow-up where we know who's getting what when. We can control for that. Make sure the babies are similar in their problems and their morbidities, and really then look at outcomes and adverse events and try and figure out if really everybody running to transcatheter is the way to go. We think this is an important study because it raises a new way to fix the duct over the past decade, transcatheter closure. The numbers are big. The trend is impressive, but the outcome data right now needs a prospective study. So the beat goes on.
Nice one. While we're talking about things that need to be studied, I know that we have a problem affecting morale in our profession, which is healthcare-associated workplace violence. Some people say it's getting worse. I have seen it in my own workplace, and I can't say that I know whether the victims actually reported it appropriately or just kind of went on about their jobs. Is there a way that we could figure that out?
Well, there is a way. I mean, sadly, since the pandemic, healthcare-associated violence precipitated by increased patient and family outbursts is out there, both physical violence, verbal violence, and the consequences of this are not good. This can cause injuries to our staff, enormous job dissatisfaction, PTSD, depression, and even when they're so upset by what has just occurred, it may affect the quality of care being administered by physicians, nurses, and staff in the workplace. So most hospitals, if not all hospitals, have reporting systems that if you are a victim of verbal or physical violence associated with patients and families, then you need to report it so we can help those employees and at the same time figure out how we can stop this violence from occurring. And the question is, are people truly using the reporting lines to report particularly the verbal episodes as well as the physical? So Dr. Mark Waltzman at Boston Children's Hospital and colleagues decided to say they're not sure that we're getting all the reporting that we can for when these episodes occur, and we must find them and do something about them. So they turned to artificial intelligence and natural language processing. In fact, their title of their study is The Surveillance of Healthcare-Associated Violence Using Natural Language Processing. For those people who don't know, natural language processing is a form of artificial intelligence. It's where you train computers to machine learn the ability to interpret either spoken language or written language. And in this case, Dr. Waltzman and colleagues decided the most important thing that they could do was look at nurses' notes. Because if you think about it, when nurses are changing shifts, if somebody's been abusive, they might have been too busy to call it in, but they're going to turn to their partner and say, before you go into that room, I need to tell you about that patient. So the paper explains the model. The paper explains the internal validation in a large tertiary care children's hospital. You can sort of guess which one from the authorship. And then it decides to take the model outside to a community hospital with an inpatient pediatric floor and apply to, again, you can think there are thousands of nursing notes. So they fire the natural language processing into the electronic health record in this community hospital. And then that computer identifies 26 episodes over a period of 6 months of hospital-associated violence. And they then validated that manually and said, yeah, these fit criteria for what should be reported to our hospital. And what they found was only 7 of the 26 episodes were coming in through the hospital reporting system. And the rest were going unnoticed, except for the fact that natural language processing made a difference. So why is it so important to get those cases that are being underreported of hospital-associated violence, and what can we do about it? To answer that, we got a commentary from Dr. Philip Azua, who's the CEO, Chief Executive Officer of the Montefiore Einstein Health System. And he wrote a commentary entitled The Scourge of Workplace Violence, where first and foremost, it becomes very clear that if we can find these underreported cases of workplace violence, first we can help employees. We can help them stay on the job. We can help them feel better. We can surround them with the services they need to say it's going to be okay and even more. Number 2, we can use natural language processing to find out where these episodes are occurring and go upstream to stop them by even identifying risk factors in the notes that can help us identify what are ways to reduce the frequency of these episodes from occurring. Dr. Azua shares his own lived experience with these kinds of episodes, what has been happening in his health system, and what they're doing about it. This is a really important use of artificial intelligence, of AI. I mean, it's very controversial in medicine right now. But if you're looking for some of the positives, if we can find underreported episodes of hospital-associated violence and do something about it, well, then reading this study and commentary won't hurt a bit. Serious topic, and I don't mean to get light about the hurt a bit, but this is really an important and useful application of artificial intelligence to make a difference and reduce the violence. Obviously, we need to do more with our families to reduce these episodes from occurring, but let's find them and go upstream and do something about them.
I like that, Louis. It's a start.
Absolutely.
And I'm going to bring us back to the start because during her 6-month visit, Zelda got her routine vaccines. And to be honest, I can't wait till she gets vaccinated for everything. But getting vaccinated for HPV is generally something pediatricians talk about when kids turn 9 years old. There are different types of HPV vaccine and different dosing regimens. Do pediatricians have any leeway over dosing strategies for HPV?
Well, let me inject some new information about the dosing strategies for Get that inject? I was trying to make some
I got it.
Trying to make some sharp points this month, so just bear with me. The HPV vaccine, human papilloma vaccine, we have put a number of studies showing how beneficial this vaccine is, particularly when it is given to preteens and teens before they become sexually active. And we have watched this vaccine evolve from a bivalent to a quadrivalent to now a 9-valent vaccine that initially we thought had to be given 3-dose series Okay. And now it's down to a 2-dose series where you give the first shot and then basically 6 to 12 months later, you give the second shot. You are protected, effectively protected for a long time to human papillomavirus. But you know as well as I do that people forget that second shot and they don't come back for it. And so that's why Dr. Nicola Klein from the Kaiser Permanente Vaccine Study Center in Oakland, California, turned to 7 clinics in the Kaiser Permanente Northern California system and basically decided to do an open label safety and immunogenicity study saying, well, just how bad is that vaccine if we don't give the second dose until later? What happens? And so she found, basically, she's running a prospective study where she's enrolling children between 9 and 14 years of age, teenagers, giving them their first shot and then having them come back at 1, 2, 3, 4, 5 years after getting the first shot. But she also found and her colleagues in starting the study that there were individuals who'd already gotten the first shot and said, well, wouldn't it be interesting, and they were out past a year, wouldn't it be interesting to see what kind of immunoprotection they have? She called this group Cohort 0, and then give them the second shot past a year. It's not elegant. We're going to do it more elegantly prospectively. And just out of curiosity, see what kind of immunogenicity and safety can we provide when we give that shot after a year? Because some people might say, well, it's past a year, we got to start again, or it probably didn't work, or you're probably going to be at increased risk for getting human papillomavirus because you didn't get the second shot. So this particular study found 146 teenagers with a mean age of 13 in these 7 clinics who had already gotten one shot. And they ranged from basically 12 months to 53 months when they showed up and said, oops, I forgot to get the second shot. So they measured the seropositivity just before giving the second shot. And it turned out it wasn't 100%. You need that second one. It was 22 to 59%. But after 1 month after getting the second shot, even as far out as 53 months, turns out they got 100% seropositivity. And from a standpoint of safety, was there a problem going that long and giving the shot? Just mild to moderate soreness in the injection site, but no serious adverse events. What makes this study even more special is that they asked these people, these families, how come you didn't come back? And if we were giving you the top 2 reasons, number one, and you could probably guess, number one is, I didn't know I needed a second shot for my child, despite us saying you need a second shot for your child. And the second one was, there was this thing called the pandemic, and it prevented my child from coming back in for that shot. And I guess isn't there a vaccine we still need to get? So this is a very small number of patients. And what Dr. Klein and colleagues are doing is doing it much more formally. But when you have a patient in your office who has missed that second HPV 9-valent HPV vaccine, just smile and say, we're still going to give that second shot, even if it's past a year. Is it foolproof? We need to get more numbers. We need to do a more formal prospective study. But for the moment, this should boost our confidence about the fact that you can go a longer interval and still have this vaccine make a difference and reduce cervical and other cancers that have been associated with human papillomavirus. Really important fun fact to know that you can increase the interval if you have to, but ideally, let's still try to give it between 6 to 12 months as that second shot.
Well, Liz, we love these intervals when we get to see you and talk to you. It's been so educational as always. Do you have any last anticipatory guidance as we go into the end of summer?
Well, I hope. Are you taking time, either of you, this summer for a little vacation?
Not exactly.
Not exactly, because it raises the. Well, that's good because everybody should go on vacation. But basketball players, they don't go on vacation. Do you know why?
They travel on the court?
That's right. Well, they get called for traveling.
Yeah.
And while we're on that,
I don't even know how
we're not supposed to guess right.
I don't think I
hold on a second. Here's a better one. Why don't mummies go on summer vacation? Well, they're too scared to unwind.
There we go.
And I'll leave you with a little, if we're talking about anticipatory guidance, you need to have good footwear when you're out there in the summer. And what kind of shoes do frogs wear in the summer?
You know, David. That sounded like you knew.
Do you have it, David?
No, I'm dreading it.
Frogs with tiny shoes.
Very close. No, you're very close. They wear open-toed sandals. For the summer, frogs. We're open-toed sand. Well, I'll just
I have a
that took me a
zoological
minute.
problem
Yeah.
with that.
I will hop away, but I look forward to seeing both of you at the National Conference and Exhibition in September, and we'll pick it up from there.
Dr. Lewis first, thank you so much for joining us today.
Always a pleasure.
For these articles and more, go to aap.org/podcast.
Coming up, we'll look at ways to improve oral health care for children with developmental disabilities. Joanna, we just talked about Zelda's 6-month checkup, but we didn't talk about teeth. Has she started teething?
She has. She has 2 little sharp teeth, and I have been trying to be good about using a soft toothbrush on my finger for her every night. But she is a 3rd child, so sometimes it's every other night.
I remember the 3-kid lineup at the sink when mine were young, and it was a lot to manage. But when children have developmental disabilities, dental care can get even more challenging.
It can be challenging, and to help pediatricians and parents deal with some of those challenges, the AAP recently released a new clinical report, Oral Healthcare for Children and Youth with Developmental Disabilities. And today we will brush up on our knowledge with one of the authors, Dr. Elise Sarvas.
Dr. Elise Sarvas is a pediatric dentist and senior associate consultant at the Mayo Clinic. She's also a member of the American Academy of Pediatrics section on oral health. Elise, welcome.
Thank you so much for having me.
So, Elise, this report focuses on children and youth with developmental disabilities. How are we going to define that population?
Of course, it's a very heterogeneous population. So it's a subset of children with special healthcare needs, but really we're thinking about children who have lifelong health conditions when we're thinking about children with developmental disabilities. They might include syndromes or other things like cerebral palsy or autism spectrum disorder. And so those are the individuals we were really trying to focus on in this report.
And as a dentist, can you share what considerations you have in mind when you're seeing a child with developmental disabilities?
Sure. Children with developmental disabilities have both medical conditions that affect their oral health, but also the treatments of their medical conditions also may affect oral health. I think of children who get antibiotics dosed in sugar that need to take them multiple times a day, that we think about those antibiotics helping the rest of their body, but it's also maybe causing them to have a higher risk of getting a dental cavity.
And are you looking at other things like how you're going to position the patient and how you're going to do your exam? What are you thinking about there?
Of course, every kid with a developmental disability comes as an individual. And so we're always just trying to position them well. So if they have a neuromuscular disorder, making sure that they are positioned correctly so we're not going to cause any damage, but also meeting them where they are. It might be the first time they've been to a dentist, or they don't have the participatory ability to really understand what's happening in the clinic. And so we work with those kids and desensitize them to our environment, which is loud and noisy and smells weird and can be scary for these kids.
I've always thought it was odd how we keep the teeth separate from the rest of the body and mind. Can you break down these barriers for us and talk about the interplay between dental health and other health issues we think about?
Historically, they've been separate because when dentists were starting the profession here in the United States, they asked to be part of a medical school, and the medical school said no, which I think now we're really understanding that probably wasn't the right way to go. And we're coming back together. And so we're finding that oral health is now taught more in residency programs, especially pediatrics, and in medical schools. So I'm encouraged that we're going in the right direction. The mouth is one of the first signs where we can see inflammation in the body. It's also one of the areas where we intake a lot of nutrition that affects the rest of our health. We are understanding more that oral disease can affect other body systems, such as cardiac systems or our joints or even our gut. And so keeping one side of the body really healthy, such as the mouth, can have implications for the rest of the things that these individuals especially might be dealing with, knowing that they have more medical burden than a child without a developmental disability.
And we think a lot on this podcast about issues related to equity. Is this a population that faces specific structural barriers to care?
They face so many structural barriers to care. I think about accessibility for them, trying to access physically the spaces that a dental provider might be in, so a dental office, And that includes even transportation. A lot of individuals with developmental disabilities are wheelchair users, and so that might be a challenge. The availability of providers for this population is one that I think about a lot. There are dentists in the United States, but not everyone is comfortable seeing an individual with a developmental disability. And it might also be an access standpoint for insurance. Most of these kids are covered under state programs or Medicaid, but a lot of dentists don't take those reimbursement programs because they don't reimburse enough to keep the lights on in a private dental office. And so that creates other barriers as far as like financial barriers, lack of payment. And then just it's hard when you're a parent of a child with a developmental disability. You're just trying to get to all the other appointments that child might need. And so dental often falls by the wayside. We have families in our clinic that say, I was just trying to take care of everything else. And I say, of course you were. We'll take care of your teeth. But the barriers are numerous, but I think we now understand where those barriers are, and we can start to address those.
And at least some of the children I care for need to have sedation, even for routine dental care. It's not always easy to find dentists who are comfortable with this process. How can we as pediatricians work with the dental community to coordinate care for these children?
We as pediatric dentists and dentists in general are so thankful for our pediatric colleagues to help us advocate for this. It may be that a hospital doesn't have a dentist on staff because it's hard to pay for them in the medical reimbursement schemes that we have currently in the United States. It could be that the hospital won't be able to see all the children who need to have their dental care done. Some children with developmental disabilities need to have their dental care done under sedation. When this happens, some hospital facilities are equipped to see them, but some children with developmental disabilities need tertiary care, and so they have to go to a tertiary care hospital to have that sedation done safely. And making sure all the pieces fall into place, having the dentist, having the appropriate facility, really could be a challenge, and especially if you're in a geographically rural area.
And what can we as pediatricians do to assess our patients before they undergo sedation or anesthesia for dental procedures?
I think number one for us is making sure the child is healthy enough. We as dentists do not recommend a child go under sedation just to take a look. We try to do all of that in the clinic. We really want to go for important reasons, either to fix known disease or to gather more information. We might see that there's no disease active, but we don't have radiographs, and so we can't rule out all pathology for a child. So a pediatrician can help us make sure that child is healthy enough. They can also help inform us if that child might have other medical procedures coming up that we can combine the sedation for. A really common one that I end up combining a lot for in my practice is for other scopes, like a GI scope, or for a child to get ear tubes. And so if we can do those together and save them a separate anesthetic appointment, that is wonderful. And I love working with my pediatrician colleagues to coordinate those.
And we have had discussions with pediatricians about transitioning children and youth with special needs to adult care, but I imagine similar challenges exist when it comes to dental care. Do you have any tips for managing that transition?
Much like the other reports by the AAP, I love that the pediatricians are starting to have those conversations very early on. Pediatric dentists need to have those conversations early on to either transition to adult dental care, or a lot of pediatric dentists end up keeping individuals with developmental disabilities in their practice far beyond what we would consider a pediatric patient because there's nowhere else for them to go in the United States. Pediatricians really help us because they can help coordinate those other oral health services and find other resources. So if they know of a general dentist who's accepting individuals with developmental disabilities, they can help us coordinate that care. But I agree with the other reports saying we have to start early. Around 12 or 14 is the latest I want to start having that conversation.
This report is far too comprehensive to cover completely, but we'd love to hear your top takeaways before our listeners read it for themselves. What would those be?
I hope this report helps pediatricians know what is normal oral health-wise for individuals with developmental disabilities. This can include malocclusion, so where their teeth don't fit properly together due to some craniofacial dysmorphia. But I also hope it takes into account like why we see children with developmental disabilities under sedation for their dental care and why that's so important. A lot of times we can't really get a good history for our individuals with developmental disabilities. And so we're working with our pediatric colleagues to figure out how to assess pain. Is it pathologic or physiologic? Is it related to teething or is it related to something else? And then I hope they understand that we've done a lot of work looking at sedation for individuals with developmental disabilities and making sure that we're doing it in a very safe and appropriate way. We hope it is a comprehensive view in case someone comes into your office and has some dental questions, and is a good jumping off point to have that connection between the pediatrician and the dentist.
Well, it is very comprehensive. And Dr. Elise Sarvas, thank you so much for joining us today.
Thank you so much for having me. It was my pleasure to be here.
To read the clinical report, Oral Healthcare for Children and Youth with Developmental Disabilities, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, I just came back from what may be my last annual leadership conference at AAP headquarters in Itasca. And it was such a joy, as it always is, to be surrounded by so many inspiring and dedicated pediatric leaders and to hear all that they're doing in their communities to help kids and know that there are a lot of people who get this mission and have dedicated their lives to it. And I'm just coming back inspired to do even more.
Oh, that's amazing. Speaking of kids, my Say Ah is about my children.
Yay!
My son Simon did his first zip line at camp.
Oh my gosh.
And I was just so proud because he's been so scared of it, but he just really took to it, and his counselor was really proud of him. And it just seems like the best summer experience.
Oh my gosh, you got a little Spider-Man on your hands there. That's
exactly. Great. So fun.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer. And Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about how to support grieving children and families after someone dies.
We'll speak with an expert in bereavement, Dr. David Schoenfeld. I'm Dr. David Hell.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.